Right. So I'm going to take a step back and just explain kind of as an overview of what do we mean when we say forensic services? What do we mean when we're talking about a forensic population? So although it kind of sounds like it, we're not talking about dead bodies, we're not talking about autopsies and all that kind of stuff. When it comes to forensic psychology or forensic psychiatry, we're looking at the intersection between mental illness and the legal system. And so the individuals that I work with, I evaluate, I oversee their care of are individuals who have some sort of severe mental illness or at some point in time had a severe mental illness. And they also engaged in illegal behavior, allegedly committed a crime, and they're kind of stuck in the criminal justice system. But their mental illness is such that it gets in their way of proceeding. And so my role within statewide forensic services is kind of broad. And so I oversee the evaluation of individuals with severe mental illness in the legal system. I also oversee the evaluators conducting those evaluations of people. I oversee the treatment of individuals who have severe mental illness and are caught up in the legal system, and then also oversee the supervision and management of those individuals when they're in our state hospitals, when they transition into our group homes, or they transition into, say, our res care, community living facilities, and ultimately back into the community. So lots of different pieces at kind of all levels of forensic services, and that's mostly adults. In the state of West Virginia historically has been adults only. However, in the past few years, the state of West Virginia now has law that we are to conduct competency to stand trial evaluations on juveniles as well as adults. And so that's been an interesting project of developing from the ground up all of those services for juveniles. And that's where, you know, I still get to have meetings with Dr. Swagger when it comes to all those juveniles and Medicaid and things we can do. I just dropped her name in some conversation the other day, and I don't even remember the context of it. Oh, I do know what it was. One of the big issues in West Virginia, of course, is resources, and forensics in particular. We're trying to build a continuum of care with lots of different levels. So we've got most restrictive, we've got people in psychiatric hospitals, but we want them to be in the least restrictive environment. I know that Anastasia knows a lot about that with her work in the CED, but we're trying to get people where they're safest and where the public is safest. And we don't have a lot of options between hospital and at home in the community by themselves. And we're trying to kind of build up those resources. And I was doing some research about Oregon, and Oregon just passed, I don't know, some kind of law or code that actually they have gotten Medicaid to pay for supportive housing services for some of their mentally ill individuals. So that's where I was like, oh, I should pull Dr. Swagger into this conversation. And she's looking at me like, no, please don't. So I guess when I take a step back, when we talk about people with severe mental illness and the legal system, there's a lot of different places that people could interact. Let me see if I can pull up a screen share something real quick. Anything. Okay, I'm going to share my screen here. Please ignore my millions of tabs. See if I can do this.
It's looking good on our end.
Okay, hold on one second. I'm going to stop share and reshare. Maybe. Okay. Do you see an image, lots of colors?
Yes, ma'am.
A little bit bigger, maybe. Okay. So this is kind of a nice way to think about severe mental illness and the criminal justice system in general. This model you're looking at here, this is coming out of SAMHSA, and this is called the sequential intercept model. And this was a model created, I think, 2006. And it was each of these intercepts are a stopping point in the criminal justice system where individuals with severe mental illness could be diverted out. And so our goal in forensic services right now is to build this extensive model across the state and start getting people out of the criminal justice system earlier and in different places. And so, when I'm saying severe mental illness, broadly speaking, we're talking about people with like severe psychiatric illnesses, schizophrenia, bipolar disorder, severe depression, post-traumatic stress disorder. We're also talking about intellectual disabilities, cognitive impairments, neurocognitive disorders, traumatic brain injuries. We're also talking about people with substance use disorders as well. And so think broadly when we're talking mental illness with this population. But what we want to do is kind of use this model to talk about what services are in place in West Virginia, what services we want to put into place, and then we have to figure out how we're going to get the money to do so. And so think about this model as different places that we can get people out of the justice system, get them out of jail, try to make sure that they don't get arrested, because we, unfortunately, we're kind of in what I like to call, well, deinstitutionalization 2.0. So if you remember your history of psychology, deinstitutionalization took place in the 70s. That's where we said, okay, we now have medications that will treat severe mental illness. We can no longer keep people in large psychiatric hospitals like Weston State Hospital for their entire lives. We have the ability to treat them in the community, and that should be our goal. And so we, across the country, we drastically reduced our number of inpatient psychiatric patients. And the original plan was that all of the money that would have gone to keep that patient in a psychiatric facility, those dollars were to go directly to community mental health services. And we were supposed to now care for those individuals in the community using the money that was already being spent on them in the secure setting. Well, lo and behold, that didn't happen. That the trickle down of money didn't happen. And so we released a ton of individuals back into communities that were not set up with appropriate levels of community services. And so over time, what has happened is that we still don't have the appropriate levels and the different levels of care that we need in the communities. And we've seen a huge shift that when we initially in the 70s, we had a huge psychiatric population, but our jail population was pretty small. And we have reversed those two. We now have a lot fewer inpatient psychiatric beds across the country, but our individuals with mental illness in our jails has skyrocketed. And jails across the US are actually the largest providers of mental health services. And so, as you can imagine, jail is not a good place for probably anyone to be. They're crowded, they're dangerous. People decompensate physically, people decompensate mentally. There's risk of attacks and assaults. And we actually know just logistically that if a person remains in jail while waiting their legal proceedings, they are like exponentially more likely to plead guilty to a crime, whether or not they actually committed the crime. And so we actually know that getting people out of jail on bond or by diversion is the best option for everyone across the jail system. But in particular, it's really important for the individuals with mental illness not to be in our jail and or prison system. So how do we go about doing that? Well, the first intercept in the sequential intercept model is intercept 0. This is community-based services. So this is prior to any contact with law enforcement or the legal system. What services do we have in place for people with severe mental illness to keep them stable in their communities? And so you'll see here that they talk about crisis care continuums and crisis lines. I'm sure many of you know, but starting last July, we now have a 3-digit number that you can call for a crisis mental health hotline. So we have 911 for emergencies, but we also now have 988. Did I get that number correct? Hopefully somebody will correct me if that's not the right number, but I believe it's 988. And that I think will takes you really to like a suicide hotline, but they can also assist you with other mental health services and needs. And so these are just a few examples of things that can take place at Intercept Zero. But the idea is that if we are providing a solid continuum of care and good community services, we should be able to keep a lot of people with mental illness in the community at this level, never interacting with law enforcement. All right, thanks, Elizabeth. Yep, 988. And then the next step in the sequential intercept model, so one level deeper into the criminal justice system is Intercept 1, and that is individuals' interactions with law enforcement. And so think of this as the time right at the time of arrest for a charge. So this comes into play when someone calls 911. And this is when local law enforcement gets involved in an individual. Unfortunately, sometimes what we see both with our severe mental illness population and with our IDD population is that family members will call due to a behavior crisis. And maybe they're calling law enforcement to ask to get a mental hygiene, to do a mental hygiene or petition for the individual to go to a facility. Maybe they're just calling because they're distressed or they're being threatened with harm, and they just want their family member to be safe. Well, what happens is law enforcement goes out to serve the warrant, to bring them in, to have them evaluated. But sometimes what happens is that they are aggressive towards law enforcement, or law enforcement feels that they were aggressive or they did harm someone in the community. And now we have legal charges because a person is having a mental health crisis. And our way to deal with the mental health crisis is to involve law enforcement. And so that is how some of our individuals find themselves in the justice system. So this model would try to say, okay, are there things that we can do? Are there services we can put into place? Are there ways that we can guide and aid law enforcement to divert people out of the system? So basically, can we find ways for them not to arrest a person if what the problem is a behavioral response to a severe mental illness, behavioral response to intellectual disability, or even if it's a substance use disorder response, would it be safer or better for this person long-term to take them to a crisis stabilization unit or bring them to the emergency room and divert them out there and never arrest them? So then they're never becoming part of the criminal justice system. We then go to Intercept 2, and so those are for individuals. We're going again deeper into the criminal justice system here. Now we're looking at their initial detention and their first court appearance. And so this is the point where they're initially detained. Can they be given bond or some sort of alternative that lets them be in the community while waiting their charges? And West Virginia has a bond system, and actually was participating in a research study this recently, and they were asking a lot of questions about our bond system and that I really don't know the ins and outs of, but I don't believe that we don't have any system in place to really help people with severe mental illness when it comes to bond. It's really just do you have the money to be released released into the community? And then when you talk about first court appearances, this is where prosecutors decide, am I going to move forward with charges? So this could be diversions, and you'll see the lines here that go to specialty courts. This could be the place where you could take people who have severe mental illness and we can put them in specialized courts. We can put them in mental health courts. We can have them be involved in drug courts, both juvenile adult drug courts, adult drug courts, and family treatment courts, which is drug court for families involved in the CPS process with their children. And so we can kind of divert them out of the regular jail system into the specialty court system. Maybe we could do some kind of alternative disposition here where they go to mental health treatment, and as long as they comply with their treatment, their charges will be dismissed after so many days. But if the person is still involved in the criminal justice system, if we're not diverting them out, then they drop even lower into the system. They're placed into jail. they're placed into jail, and they have dispositional court. So this is the whole process of everything prior to being found guilty, to the time that they're found guilty and enter. This is the big place where everything from pre-trial all the way through being convicted of the crime, being sentenced for the crime, their time in prison for that sentence, if that happens. And then we dropped to intercept 4, which is the process of reentry services. So all of their kind of incarceration falls into this jail piece. Well, forensic services, when we're doing what we call competency to stand trial evaluations, we're looking at people who currently have a severe mental illness, and are not able to understand the court process and or can't work with their attorneys right now. And so we divert them out of jail into Sharp Hospital, where we work to restore their competency, get them stable on medications usually, teach them about the legal system, and then they come back into the jail process so they can kind of have their disposition, meaning, are they found guilty, not guilty? Are they sentenced to prison time, jail time, community corrections, or released? And so forensics plays a role there in the competency process. We also play a role of individuals who were severely mentally ill at the time that they committed their crime. And because of that, they didn't understand the difference between right and wrong, or they couldn't stop their actions. And so those individuals also come into Sharp Hospital. We have a lot of systems in play there to they have oversight by judges, but then based on their level of dangerousness, which is done with a risk assessment by an independent evaluator, we determine the least restrictive environment for them, in which maintains their safety and the safety of the public. And so that's where forensics also kind of diverts them out of jail and prison into more treatment because of their severe mental illness. And then if the person goes further into the justice system, they've done their time in prison, they're getting ready to either go on parole, or they've reached the end of their jurisdiction. And this also is where forensics kind of comes back into play, because we have individuals re-entering the community on conditional release. And at this point, we need to kind of determine what do they need in order to be stable back in the community. And so are there any therapeutic services we can put into play here? Are there different types of medications that we can put into play at this point in time for individuals with severe mental illness, so that they're successful when they re-enter? And then intercept 5 is when they're actually back in the communities. And some people, they may go from disposition all the way down to straight to community corrections, because they might go straight to probation, or they might go straight to parole. And so then what are we doing here in the community to maintain both the safety of the public and also the safety of these individuals, as we know that people with mental illness are much more likely to be harmed by others than they are to harm others themselves. And so forensic services comes into play with conditional release plans. We place people into forensic group homes. We place them into other independent apartments or transitional living facilities, where we're helping to teach them as independent living skills so that they can ultimately live on their own while having some oversight by the justice system. I apologize. I'm getting a whole bunch of notifications. So this is kind of the nutshell of of a model of where does mental illness fall in the criminal justice system, and how do we work to move people with mental illness out and into the community, or into the least restrictive environment that is most successful for them. We're looking forward in the next 6 months or so to really take a stronger look at this in West Virginia and kind of build up some of our resources. I will stop my share there. Let's see if we have any questions.
Any questions from the group? I've been, Dr. Swagger.
Oh, I'm always going to pepper Colleen with questions if no one else jumps in.
Please jump in, others.
So I'm still in the learning phase about the process, especially around forensics with kids, and I know that's a work in progress. I'm seeing a lot of kids. Well, it's twofold. I'm seeing a lot of kids that I think in the way things used to be sort of mentality, people and systems would try to get kids to get charges and go to BJS as a way to facilitate their treatment to residential. And so I've seen proactively lawyers or DHHA workers, I think from a good place, trying to get kids charged with things, thinking they're going to get them into care. And I appreciate that back when, before CSED and some of the other services had really expanded and PBS, that those options were limited, and there were sometimes more options in DHHR's reach than parent placement, but some pretty profound examples of that. And then when they get to BJS, because they now have been charged not with simple things like incorrigibility or whatnot, but they're charged with like grand theft auto or something quite severe.
Because the court has now said that you can't go to BJS for a status offense.
Well, which is good, because that's what most of them are. But now they're getting crazy nuts things that don't make sense. And the one I saw yesterday was a 13-year-old charged with grand theft auto. But the clinical backstory was, of course, that mom probably had a substance use disorder, and mom had sort of refused to participate in outpatient care. And it really probably should have been an abuse and neglect case for the parents. But of course, they didn't do that. So they put her in BJS custody. She had a history of doing well with another family member with treatment too. And so she was now, and this was sort of the catch-22 of it all, that she's now sitting in BJS with a really serious criminal charge, and had some type of evaluation that gave her the diagnosis of conduct disorder, largely because she has been now charged with running away and grand theft auto, which is the definition of conduct disorder. So you gave her a conduct disorder diagnosis. And then sort of people articulating, we don't really think she has conduct disorder with that charge. We just think she has trauma and needs coping skills. So of course, all the mental health facilities will absolutely deny her because she has conduct disorder, and you charged her with grand theft auto and are not, and so that sort of becomes the catch-22, and then sort of the role that for the competency evaluations play. I mean, there's also this sort of misguided thing that and they're like, well, we think she's competent because she can say back to us that she understands the law, and I'm like, that's not even what competency is. And then they expect the competency evaluation to include the treatment recommendations, which is not the same thing. And sometimes there's a massive disconnect from the treatment recommendations and the competency evaluation, because they'll say they need residential, but don't differentiate what level of residential care. And so, I mean, I'm sure that you've seen this in the adult side too, but
I feel like you were hiding in some of my meetings lately.
Well, yeah, well, because they see them all the time. And so I mean, from a clinical perspective, I'm often articulating at that point to send kids to diagnostic facilities, which I have to tell you, I completely disagree with, because I think diagnostic stuff could be done in an outpatient community setting. But it seems so much better of an option to have a good clinical assessment than to make massive decisions about going to detention and competency. And so I guess
now what's happening is those diagnostic centers with providers who are not trained to do forensic evaluations are being asked and are inappropriately saying they're doing competency evaluations, which are competency evaluations, and they're giving kids that are 15, 16 schizoid personality disorder.
Yes, yes,
diagnoses. And I'm like, you are so inappropriate right now. What are you doing? Yeah. Yes, we are having all of the same conversations on the other side. Not that there's sides here, but you guys are having it from the kind of the payment and Medicaid and what do we do side. And from forensic side, I've been working with Juvenile Justice Commission and BJS because they're just as frustrated that, Cindy Largent Hill, the Juvenile Justice Commission, is like, if evaluators just stop saying conduct disorder, we would be okay. Like, can we just like not allow them to make that diagnosis? And I'm like, well, I don't ethically think that I can step on the toes of an evaluator and tell them they can't make that diagnosis. But I don't think people realize the ramifications when they make a conduct disorder diagnosis on a youth. I think that, and this is where, as a clinician, I know I have struggled. I can see a kid and I can say, these symptoms all feel very trauma-based to me, but they do not feel, I don't know how to turn this off. I can say all of this feels very trauma-based, but I don't know if they really meet criteria for PTSD. And then I feel kind of stuck as an evaluator of, I don't know that we have a great label to put on a kid who has had a lot of trauma and a lot of issues and is reacting to that, but maybe doesn't fit into a box.
Well, and I think that's a really important part about kids that's different. I mean, I don't feel compelled in the kid world to make sure that diagnosis is 100% accurate the first time I do that, right? Because most of the time diagnoses and symptoms have to evolve. So even if there's an appreciation of what do we call them, Z code now, of abuse and neglect and patterns that look like trauma, that need further explored and treatment, would be a better articulation. I mean, more of like, the diagnosis is part of it. And people, of course, go right to that, just like they go to full scale IQ and kids have massive deficits and gaps, and they stick to one thing. And actually, I mean, I would argue that that's more problematic. I mean, in the world, my world, like using a general diagnosis like a disruptive behavior disorder, or using a general diagnosis like a trauma disorder unspecified would be a far better sort of thing, and to be as the touch point of a clinical, I mean, a true clinical assessment doesn't expect that the diagnosis is made the first meeting. In fact, I would
a forensic assessment and the courts expect a diagnosis made in that first setting, and they expect a definitive diagnosis. They dislike,
but that's not consistent with development, right, in children,
which also tells you this is why a diagnostic evaluation and a full psychiatric psychological evaluation is going to look very different, could look very different from a competency evaluation. They may just be two very different things, and we need to not conflate them. And yes, I agree with you. We are getting, and part of it is a miseducation. I know that CPS is asking evaluators to do full-scale IQ testing on every competency case, because they know that placement over there needs an IQ test, and they just want to get it all done at once. And I know that CPS is telling evaluators, hey, that placement requires an IEP, so I need you to give that kid an IEP. And then the evaluator turns around and says, hey, this kid needs an IEP/504, and the child has 115 IQ.
Exactly. And I think that's the disconnect. The competency evaluations are trying to answer questions that they didn't evaluate for. I mean, ultimately. And so like, you can't, I mean, the disconnect, I mean, even sometimes the diagnosis I get and are probably accurate, like from what they wrote, but the treatment plan's completely disconnected from it too. I mean, I saw one the other day with an IQ of 53 that, of course, she wasn't competent, but then they went into treatment planning, and I kid you not, she needs residential treatment and CBT to address her anxiety, when they gave her a conduct disorder diagnosis and moderate. I mean, it didn't even make any sense. It was really like, I mean, and maybe that's exactly what happened.
The treatment plan. It was the evaluator laid out a treatment plan.
Yeah, like, or I don't know. I mean, this is where I don't understand the process, because I'll show up at these clinical reviews. I mean, my goal is to try to assist in what level of care they need to go to get treatment. And lots of times they're sending me these evaluate. They've already been evaluated, and it will truly be the competency evaluation. But then it'll launch into these recommendations that don't make sense. Like, they just aren't consistent with evidence-based care, even sometimes for the disorder with which they led with. And so that makes sense to me if people are sort of coaching them to to say things, because it's kids that will get these severe conduct disorder diagnoses, and they're trying to coach them into what sounds like a mental health diagnosis, but nothing else in the evaluation supported it. And then like when you have an IQ of 53, if you're like telling me they need, and she was 11, needed a individual CBT based treatment for disruptive behavior. I mean, like that doesn't even compute. Like, I don't even know how, and they don't know, like DHHR and the system doesn't know. It sounds lovely, but then they get frustrated because they send referrals, right? And everybody denies them because the clinician on the other end knows it looks like complete garbage, and it's find a bed instead of the right bed. And I guess, so my question to you, like just with the current state of things as we build the ship, right, is I don't know what I'm supposed to recommend. I really want these kids to get more complex evaluations. And I've become very consistent if they have not had previous treatment or previous good information. I find myself saying they need diagnostics because I don't know what else to say. But from a Medicaid side, we don't pay for 30-day diagnostics. So these become fees that get charged to the state, because a true diagnostic evaluation is an outpatient recurrent clinical progress over time, right? And so it becomes, then I'm like recommending something that's not even a medical service technically, or not covered by Medicaid. It becomes, so I don't know the solution, but sort of what would be the best non-bad sort of recommendation to be making at this point in time, because sometimes they're even doing referrals for care before the competency evaluation while they're sitting in BJS, and then it's even more like I don't know what to tell you.
Yeah, I don't know quite where to begin. I know that we need to begin with education. And I know on our side, it sounds like that's what you're doing on the clinical review side. That's what forensics is trying to do on the other side. We're about to start the traveling roadshow. I've got judges, prosecutors, defense attorneys, conferences all in the next month and a half, May and June. And we are doing a recorded training for all guardian ad litems on juvenile competency. What should the reports look like? How will you know if you've got a good report? What you should be looking for in a report? I'm doing that in coordination with Judge Ewing out of Fayette County, I think he is. So he's going to talk the law side for the guardian ad litems, and I'm going to kind of talk the evaluation side. And so I think maybe you and I should get together and have a conversation as I create that training. That training is going to occur on the 19th of Juneteenth. We're going to run that training. And so I'm hoping that if we get guardian ad litems really educated, they can look at the reports and be like, no, this is not okay. I don't want this. I'm going to stop using evaluator X who's doing inappropriate reports. That's how the justice system would want to work out some of these issues. I know that's not how DHHR works out issues. They want who's going to be the cheapest and who's going to be the fastest, and they just want an eval so they can just get a placement. I got Suri over here listening to me, sorry. And so I think number one,
so including in that education that once the question of competency is answered or not answered based on the information we have, that the true evaluation after that decision should be if there's a concern regarding a mental health diagnosis or treatment that they need like a full clinical assessment for level of care.
Yeah, so the issue we're going to run into, because I know we looked at this, I'm looking at the juvenile code. The juvenile code tells the evaluator that in the report they have to include their procedures, background on the child, including education, psychiatric, psychological, developmental, and family history, mental status examination, a diagnosis if one is going to be made, an opinion as to the juvenile's developmental maturity or developmental immaturity as it affects competency. And so it ends there. And then it says, if the evaluator finds the juvenile not competent to proceed, then they're supposed to answer the questions of whether they have a developmental disability, intellectual disability, or mental illness, whether they have sufficient, then they're talking about the competency questions, sufficient rational ability. So there, it goes down to a bunch of other things they need to add. And then there's, if they say the juvenile is incompetent but can attain competency, it then tells them that they should make a recommendation as to the treatment or therapy and the least restrictive setting. So the way the code is written is opening it up for evaluators to do broad speaking treatment and therapy. What we're hoping to change the code to say is a recommendation as to the treatment or therapy needed to attain competency. And we think if we add that last little piece, and if we train everybody that that is what is intended by that statement, we can limit what recommendations, and we can educate evaluators when they make statements outside of that. But right now, the way that it reads is it's telling the evaluator, make recommendations for treatment and therapy. And so I think that's where that's where this is kind of coming into play. I think people need to learn that the competency evals are
Well, yeah, and I guess my question with children, because so much of the issues are often around complex communication and family issues, that typically on a clinical end, they desperately need family work and family-based treatments, right? And yet that requires like the judge ordering the family to participate, but I mean, honestly, I have not seen one of those, maybe one or two that did a really good job. They're almost always globally saying they need to go to residential psychiatric facility with no description of PRTF or no understanding of what PRTF versus group 321 and so they blank, and then they sometimes will say, but they have not provided anything that meets medical criteria for psychiatric resident facility either, which is the hardest bar to kind of make, that's rarely met at that point. So and the bar for PRTF is that you failed at lower levels of family-based care. So I guess my question is, and I see that you can tell when you read these reports who knows kids and who does not. To be honest, there's a lot of adult people, I think, trying to extrapolate adult things to kids, or at least that's what it looks like. I don't know.
We grandfathered a lot of people into the juvenile world because on the other side, I'm getting told we don't have enough evaluators.
Of course. So I wonder if in the educational process, there needs to be educational processes about levels of care and medical, medical necessity and sort of, what the appropriate treatment is. I mean, there's not an adult equivalent for oppositional defiant disorder. It's not, it's a kid-based illness and the beholder of the caregivers that you're spiteful or I mean, like it's not, there's not an equivalent. And I think there's less of an equivalent in terms of understanding of the importance of family-based or dyadic intervention. This goes to things that, Amanda has talked about dyadic work and attachment problems. We'll get kids with attachment disorders and they'll say they need residential. It's like, you cannot solve an attachment disorder in a residential facility. Like, you can't, like, it is impossible. And so I don't know, those are some challenges that I don't know how to bridge. And certainly if it's education, I'd be happy to help in any way I can on the medical side. But in an ideal world, the person doing the evaluation could be doing good recommendations that way, or maybe it's just building out really, like you said, building out really good evaluators and getting rid of really bad evaluators. But I mean, even at face value, some of these reports are so terrible, like, and they're coming to the judge to be upheld as dogma, and it's just so wrong. I mean, it like flies in the face of like evidence-based care. And so I think, then these kids get ordered to levels of care that don't match their true clinical needs based on a bad report.
The other problem at this point is that I never see those evaluations until they come for payment. And even then, they don't really get reviewed. So one step may be getting a process to get them forwarded to us so that we can start doing some remediation with the evaluators on what these evaluations are looking like. I don't know how many cases are out there where people at diagnostics are doing competency evaluations and
it's going both. I think it might be going both ways.
I think it is. I agree. And it's happening in the adult world still. We've had this system for many years. I mean, I had a case the other day they wrote an order for WVU at Chestnut Ridge to do a competency evaluation on an adult. And it got sent to WVU in Martinsburg, or Berkeley, to Berkeley Medical Center, where a nurse practitioner did a competency evaluation. And they're like, the judge was like, this isn't what I want. And she calls me, why didn't you do this? And I was like, I didn't get the case. I don't know what you're talking about. I'm not a part of that.
Where did you send it to?
Yeah. So I do think, we had a meeting a while ago where we talked about, maybe there needs to be a special type of evaluation that you're looking for when we're talking about these different levels of care. And you almost wonder if you need to have some sort of process to say who can do those evaluations. And those people are specifically trained in the levels of care system. And, maybe not, they don't necessarily have to have that forensic training, but, making sure that this is a select group that the state has said, okay, these people can do this evaluation. This evaluation is going to give us recommendations because they've been specifically trained on levels of care. I mean, I'll tell you, I call Debbie Gillespie at BJS or Cindy Largent Hill, and I say, okay, this is what somebody just sent me. I have absolutely no idea what to do. What kind of placement options are we talking about here? Because that's who knows these placements, or can say, okay, well, if the kid does have to go out of state, this placement really works well with this type of kid.
Yeah, you're correct. You're right about that.
You need to have the right resources. But
Well, I apologize to everyone else. I am totally monopolizing your time, but I want to make sure I don't take up anyone else's questions. But let's continue this.
I do think you bring
really
up, and part of what you're talking about, I think, is that we're not utilizing the community services that are available. We're not utilizing PBS the way that it could be utilized to help in these cases. We need to pull Anastasia into forensic services.
Or CSED. I mean,
I don't really understand. CSED. DHHR CPS is now referring everybody to CSED.
So I can
Apparently.
do with Jen Ava, who's the statewide director for that, to explain to you what that entails. But in an ideal world, CSED's supposed to be the level of care you fail before you go to residential. It's designed to keep kids in their homes with intensive family and individual based treatments. And PBS is and RAP is supposed to be the service line before they get to CSED. So, and then PBS can continue to train the providers that work with CSED and the RAP providers on their educational arms, so they can build out, they can use so you can get facility-based training, or you can get, first responder-based trainings, because they have a whole training catalog. That's what Heather does. Heather, I'm sending you business. Heather is sort of in charge of all the curriculum development and sort of the training line. So they can train providers in the techniques as well. So PBS does have a core clinical program, but it's an intensive 6-month program trying to kind of get people fast and early, and actually probably more specialized in the IDD and autism realm than some of the more mental health needs, especially because there are very few people that kind of specialize in that. So that's sort of where all the pieces fit in. And I think a lot of times those evaluations come back, even with community providers for psychologicals that aren't even in forensics, they will make residential recommendations, but there's no mention they ever had any outpatient services or any of these services to fail. And then when you're like, well, they don't meet criteria to go to residential, I appreciate you're saying they need mental health care, but your level of care recommendations doesn't actually match what you say.
Is that because we're catching these kids too late? Is
Probably.
It possible that they do need residential care at this point, but
some of them, but a lot of them don't.
Oh, Anastasia, you don't have to raise your hand.
A lot of them don't. A lot of them have been have not received zero care. I think a lot of it too is with kids going through foster care and new to families, they don't know what's normal, and they need a lot of services wrapped around, and so people have big reactions to minor things because it's new and they're getting used to things too. So it's a little bit all of the above, I would say. Anastasia probably has some really deep thought here.
No, I wish I had deep thought, but I have a question about because I don't really know anything about any state services outside of West Virginia, but I've heard through the grapevine that some of the other states have some more intermediary like type of services, because what I think we're finding is that some of the kids will be on wait list for placement, and we'll start working with them, and then they'll make success, they'll be making progress, and they really don't need that placement anymore. But because they've been on the wait list and they've been searching for that bed, then they go to that bed even when they don't need it sometimes. And so, and it's almost like they're in that in-between mark of in the community, to have somebody coming in, even if like between our services and RAP and everybody, maybe even if they had a home visit once a day for an hour, it still wouldn't be enough. But at the same time, they don't need full out residential care. And I feel like there's a lot of kids that fall through that crack, like where we can
So they
really
need
help.
MST.
It's not just MST. I mean, some of the kids just had no treatment and they got better while they were waiting, like they were waiting too. And it's not MST. Most of actually what Anastasia and Heather see is not conduct disorder. It's complex trauma. It's learning challenges manifesting as reactive behaviors. It's need for more parent-child work. I mean, rarely are those kids like labeled conduct disorder at that point, I would say. But yeah, I mean, it's also like, at what point, I mean, a decision about level of care is a time-based decision. Like people will waive reports that are a year old. I had somebody yesterday had a report from May. She's trying to get a kid placed on a report from May, like, again, ignoring the fact the kid is now in BJS custody with grand theft auto charges. And I'm like, you are never going to get a level 2 facility. Like, you cannot send the May report and think you're going to ignore the fact she's in BJS custody on grand theft auto charge. It's never going to happen. Like, and she's like arguing with me, and I was like, well, you aren't getting any acceptances, and here is why. But I mean, like, it's just, again, the time frame of need, I think is really critical. And so, like, I mean, and same thing with competency, right? It's a time-based sort of thing. You can't like take a competency report and use the same report to reevaluate a different behavior later, which often kind of gets into the whole system of care too. Did I lie? Have you seen any true conduct disorders, ladies? I haven't. I don't think I've ever heard that they're conduct disorders. I think we don't see that, and I wouldn't say they need MST. Most of the kids we serve.
So
Yeah, I think a lot of ours, it is more just like the PCIT is really helpful in those kind of interactional trainings, and I think that they will thrive with some just interventions. But it is where like they'll make progress, and then it's like, oh no, now they got a bed, now they're going away, and it's like, oh no, they were right there. And
I think often the providers aren't invited to the MDTs, like too, in some of these meetings that are following, right? So I don't know who goes to an MDT. Even when I worked in a residential facility, kids were having MDTs all the time, and nobody ever invited me to give my opinion. So I don't know what an MDT is, but I don't think they involve clinicians that are actually working with the kids.
But if you ask CPS, they will tell you they're supposed to involve the therapist.
Well, that's not evident, and certainly by PBS's standard, I don't think they've ever been asked to truly make those types of things or say, I don't think the kid needs residential. Like, I don't think we're getting a seat at the table.
We need PBS. So we now have ECHO. We have CPS ECHO. I think we need PBS to speak.
Is that active?
Mm-hmm. We just had it this morning.
CPS ECHO is active.
Cool.
Yes. I can
Would you resend me the invite for that? If you did, I totally missed it.
let me send it again in the chat, because that would be awesome if you guys can attend.
I need a calendar invite. Is there like a little like
you have to register to get the calendar invite.
But I'll let Jay know, and then he can send it to you.
Well, I'll register. You may have sent that and I ignored it.
Well, we had it going on, and then we stopped it because we were getting 0 attendance. And then we tried it. We waited a couple months, and we switched the date and time. And today we had the whole screen full plus some. So
what time is it now?
It's 10 o'clock
10
on Wednesdays.
That
Yeah.
may be, I can never do 10 on Wednesdays, so that might be my problem.
I think they're recorded as well on our YouTube, so you could always rewatch or even submit questions to us and we'll have them asked for you or things like that. But I put it in the link in the chat. It's essentially our sign up link, but if you just specifically click the CPS option, then we'll get notified and we'll know to send you the calendar invite.
Ooh.
Awesome, thanks.
And I'll talk to them about adding PBS as a presentation topic, because I think that would be helpful to everybody.
Yeah, that sounds really good. I love seeing all these different echoes come together. It's always overlapped in so
Yeah,
many.
and Colleen, I think I should connect you with Jen Ava, who's the statewide CSED coordinator too, to explain what that is.
Yes. I'm getting the person that I was on the phone with before this is hopefully an outpatient forensic coordinator. And I'm hoping she can start to help continue to build all this programming if she accepts the position.
That would be awesome.
Yeah, but no, we definitely need to, it takes a village and it's going to take the whole state. And I think it takes enough people having connections with enough people. It for some reason just feels very hard to know who to contact in all the different circumstances. It's harder than it really should be.
Yeah, absolutely. We are at 1:26, so we still have a few minutes here if we wanted to continue any discussion. This has been such a great session. Heather, I see you unmuted.
Just want to thank you for such an interesting conversation. I know, Dr. Swagger, you felt like you were taking up a lot of time, but I thought it was really interesting because I've been doing this new approach, the triage. I'm sure Anastasia's filled you in on, where I'm like the first point of contact with our new clients or new families. And every single child has the same diagnoses. And it's odd to me. I'm like, how do all these kids have the same thing? Is it in the water? You know, and so this kind of puts in perspective how quickly some of these kids are just assessed. It's like checking the boxes just so that they can get services. So it would be amazing. And maybe there is, because I'm still learning all of the state providers as I'm still relatively new, you know, to the state, but it would be amazing if there was like a next step between that, like a more in-depth kind of, you know, diagnosis, or like a month to see a child before we get a more permanent diagnosis. And I know it changes because of the kids' development and their age, but anyways, the conversation was fantastic. It brought some light to certain areas that I'm always questioning and trying to figure out. So thank you.
Well, we are always available if there's other areas or you are seeing competency evaluations and you don't know why. The point of the juvenile competency legislation initially was to keep IDD and autistic children with autism out of the BJS and the justice system completely. And so, you know, there is a lot of support within DHHR to make sure that occurs. I don't think that's the kids that we're coming across, but like I said, it's kind of hit or miss at this point. I don't know. And there's a lot of like alternatives that could happen. Like, you don't need to be going through the competency process if it's a minor case, or if it's what would be a misdemeanor in the adult world. That doesn't need to do a competency. If you have a placement option, I tell those courts, just go with the placement option if it's appropriate for the kid. But when
Can I also throw out there that under like 11 with no ability for abstract thinking, no one ever meets competency. Like you can't, why do we even need I mean, it's not developmentally possible to achieve competency until you have abstract reasoning skills. I mean, like, and I'll sit on these cases, even with, and say like, how 11-year-old can't be competent. They compare it back to you, what you said, and nod their head, but there's no way developmentally that a child can do that. So why are we even putting people 11. I mean, like that doesn't.
Because prosecutors are telling me that 7-year-old is competent and needs an evaluation because he knows right from wrong. And I said, that's not the criteria for competency.
That is not what competency. Like, so I just, I mean, I mean, it doesn't make, and it just defies like logic and science. Like why, I mean, and so like, I get it. You want to punish the kid because they did a bad thing, but like, that's not really what this is about. Like, and like you developmentally cannot achieve competency before you have formal operations. Like it just, you can't, it is impossible. Like show me maybe like some savant with an IQ of 150, but probably not even that. I mean, I don't know. It's just, I've never seen an 11-year-old that achieved you know, like it's just like, it's developmentally flawed.
Yeah.
So when I see a report on a kid that's 11 and under, and they even suggest there's, I just devalue the entire report, even in their treatment recommendations, because how can you say that a 7-year-old is competent? Or, I mean, like, it just, like, I mean, it just screams that you don't know what you're doing.
And it's wasting resources, time, money, everything for that kid who, I mean, we're paying $3,000 an eval for those. The DHHR is the state is.
Is that how much they cost? Oh
Well,
my.
that's the max you can bill is $3,000. So that's why you see
It better be some quality. I hope they get some quality control in what they're paying for, because it looks terrible.
No, they get no quality control. I'm supposed to be reviewing all of them. I don't have time to review all of them. But that's why there's a lot of testing in all of them, because they can bill per the hour for the testing. And so you'll see a ridiculous amount of testing that's not necessary, because they can.
And Colleen, I don't want to like go into toes about this too, but there's another like serious thing coming out of those reports too, is that a lot of these kids have in utero drug exposure, which you know is like my big thing, and they have wild test scatter on their IQ, and they are still, and my understanding, and I am not a neuropsychologist, they should always make a correction for a global abilities index or an explanation when there is severe scatter. And there are so many people that are not doing that and reporting full-scale IQ. I kid you not, I saw a kid the other day that had a normal verbal IQ. I believe the performance IQ is like 85. The working memory and the processing speed were below 60, which dropped the math down to 68 or something. Yeah. And I was like, how can you like be basing this kid's IQ on a 68 when like the only measures that were severely impaired? I go, I don't know why he was that severe. Is that untreated ADHD? But like that's not quality control in testing either, like from my understanding. So I there are some massively poor interpretations, and of course DHHR goes immediately, because they don't know any better, to full scale IQ to base all decisions on. And I mean, some of these kids have wild 30-point spreads that don't even reflect their cognitive skill set very well, and it is really impairing like their decision making, because then they get blocked from resources they probably could participate in because they're without an option. So I don't, while I'm glad they're getting tested, I don't know about the quality of, again, I see that there's no mention of those splits or scatters. They're just reporting out full scale IQ. I immediately doubt the quality of the evaluator when I see that. And sometimes people will report it and say, this isn't accurate. I calculated this, and they do a nice explanation, but this is a serious barrier for a lot of kids.
Well, I was here to give a nice presentation, and it turned into a whole lot of work for me to do going forward, but I appreciate it.
No, I love it. And this is what ECHO's for, you know, like sparking these really important discussions. It's so important, and we could have so many sessions around this topic, you know, and I just appreciate each and every one of you for, you know, contributing in this discussion. And I do hope we do see some improvement and change, but yeah, no, we can absolutely continue this conversation as well. If, you know, maybe some folks are seeing specific cases and you just want to talk about it, we can dedicate a session to that as well. So just let us know, and we'll cater to whatever all of your needs are and desires are. But thank you so much, Dr. Lillard.
Maybe neuropsychological testing for in utero drug exposure might be a really interesting.
Yes, I like
We
that.
have
I
a
like
ton of
that.
neuropsychologists now. We could get one of them to come in.
Well, and maybe I'm not supposed to say this, but every kid I see that gets a neuropsych testing request that has a history of in utero drug exposure, I just approve it. I don't even bat an eye on anything else.
Good to know.
I again, that only applies for those with our insurance, but I think it is absolutely critical, and
Now, are you getting good neuropsychological evaluations back?
Well, there's not a lot of people doing good neuropsych, so let's start with that. Most of the people with WV are very good. There are some people doing good assessments, but there are not a lot of providers in the state that do neuropsych in general. They're mostly psychological evaluations, and actually that's, there's a lot of flaws in that. They're just giving a lot of psychometric measures without a lot of assessment of other clinical etiology. And a lot of the kids, because of how complex they are with trauma and in utero, I mean, it's like, why waste your time on a psych test report? You really need the Big Mac daddy. and I'd rather pay $3,000 for good neuropsych. No, I don't even know how much it costs. I never know what it costs. But yeah, I think. And so many times I'm that's another fallacy. I see these reports back and the kid, of course, has 10 diagnoses, anyway, we need to let everyone go. But like, it looks like it's in utero exposure, like just by the history, and all these diagnoses are coming from neurocognitive damage, that thing in the back of the DSM-5, right?
Oh, I give that one all the time.
Yeah, and
Lauren Swagger on it. Neurocognitive.
but you know what? If you give that
prenatal.
diagnosis, people don't know what to do with it, and then it blocks access to care too. So, I mean, it is quite a needed system.
So what do you want us to do then?
I don't know. Like, I was like, it's a really accurate diagnosis for this kid. And they're like, well, we don't know what that is. We're not a neuropsych unit. So I was like, that's better than conduct disorder, ADHD, PTSD, and the 500 other things that anyway. I think I'm next. I have to be next week, and then I promised another in utero substance use talk for Echo. So we'll add that to the next.
Add that to the running list. Absolutely. No, thank you all so much. Appreciate each of you, and thank you, Dr. Lillard, for leading this discussion. It's so important. I have just a really quick announcement. The next session will be on May 3rd, and Dr. Swagger will be presenting on antipsychotic medications. If you have any other topic ideas that you prefer on doing and wanted to change, you're more than welcome to. You can just let us know. But that's what we have down for next time, and we can't wait to see you all next time. Thanks, guys. Bye.